antibodies. This is a very important topic for FRCPath, especially part 1, because it has a lot of transfusion potential. So you must be well aware of red cell antibodies, how they are tested by quantification or titration, and what level of antibodies are important, especially about NTD, what dose to give if NTD administration is indicated. So our today case is regarding NTK. So the scenario is a 25-year-old woman is at 12 weeks gestation and attending the obstetric unit with abdominal pain. She is expecting her second child. Her ABO and RHD group is A negative, and a red cell antibody panel shows NTK. So now this is almost a 25 marks question. It will be given like this in the FRCPath exam. There will be sub questions to each scenario. So the most likely questions are what further questions you would ask in the history of this patient. How does the enzyme treatment affect red cell antigens? What further investigations are required in this particular case? And a pregnancy plan, which includes delivery plan and baby examination after birth. So these are the few examples of the questions given to a red cell antibody scenario. They can also ask you what is quantification, what is titration. They can give you um, a single antibody, for example, NTK here. They can give you multiple antibodies, uh, maybe NTE or NTD combination. They can ask you what are the indications of fetal medicine unit referral. They can ask you the specification of intrauterine transfusion or neonatal exchange transfusion, or the specification of intrauterine platelet transfusions. So there are a lot of possibilities in red cell antibodies scenario. So when you are preparing for FRCPath exams, prepare it like this, that so that you should not miss any uh, marks in the exam. I'm sure you all know about this, but arranging them and organizing them in the exam matters most uh, in order not to lose marks and to pass the question and ultimately the exam. According to RCOG recommendations, all women must have blood group and RHD typing along with uh, indirect antiglobulin test at 37 degrees centigrade at booking and then repeat at 28 weeks. The purpose is to identify red cell antibodies that has the potential to cause uh, uh, hemolytic disease of newborn. So the first question is, what further questions should be asked in the history of this particular patient? So this patient has now NTK in the panel. We should ask from this patient, or we should see the record of this patient, what was the outcome of the previous pregnancy, because this is her second pregnancy. Was there any antibody in the previous pregnancy? Was a pregnancy even completed? Like there is no miscarriage, no abortion, anything like that. If the pregnancy is completed, was it affected by HDFN or not? Was that pregnancy affected by any antibody? Whether this particular patient has any previous history of transfusion and formation of antibodies, because some antibodies hide with passage of time, like JKA or JKB antibodies, and whether this is the same partner or a different partner. Because if this is the same partner, we would know the genotyping of the partner if that has been done for the first pregnancy. So these are a few questions that we should ask from the patient or from ourselves, and we should see the record uh, uh, of these things um, for this particular pregnancy. And the second question was, how does enzyme treatment affect red cell antigens, papain enzyme and facin enzyme? So this is a solid mark question, um, well known for MCQs, EMQs, and for transfusion. So those antigens which are enhanced by enzyme treatment, I have learned a small mnemonic for that, which is Kid Lewis is a retired professor, and this mnemonic stands for Kid system, RH system, ABO antibodies, Lewis antibodies, I system, and P system. So these are the red cell antigens which are enhanced by the enzyme treatment. While the KEL system is unaffected by the enzyme treatment, and the two systems which are decreased by the enzyme treatment are the MNS system and the Duffy system. So if you remember this table, I'm sure you would be able to do a lot of MCQs, EMQs, and if this question turn up in the paper, you can do this easily and get full marks for that. So now the question is, what further investigations are required for this particular patient? So if you go through the scenario, this patient was presented with abdominal pain. So whenever any pregnant patient comes to our A&E, um, it it is examined by the midwife because of the pregnancy, and they do fetal ultrasound to see whether baby is affected or not. So we always involve the obstetric team, and obstetric team include midwife as well. So we should be sure that the fetus is okay. If the fetus is fine, then next important step is to establish the K status or KEL status of the fetus by genotyping. How can we do that? By taking a maternal sample for fetal free DNA at or after 16 weeks gestation. Second option is sample from the father for genotyping. So if uh, father is homozygous for KEL, big K, I mean, fetus is at risk of HDFN because if father is homozygous, the fetus would carry um, big K and mother has anti K, so there is a risk of reaction and HDFN. If the father is big K negative, then the fetus is not as at risk, and because the fetus would not have uh, any big K antigen, so no chance of reaction, no risk of HDFN. So in that case, no more further testing except for repeating the routine 28th week bloods, which will include blood group, RHD typing, IAT screen as well, and that's it. If the father is heterozygous for K antigen, in that case, we must need to do cell-fetal free DNA to confirm the baby's genotype. Antibody titer for NTK. So remember, for NTK, we do titration. We don't do quantification for the big K. Quantification is done for NTD and NT little c only. So if the big K titer is above 1 by 32, it is considered to be significant, although there is a poor correlation between risk of HDFN and antibody titers. So any levels of NTK present, the case is referred to fetal medicine unit for monitoring. So these were the few investigations that we have to do to find out the status of the fetus. Better to mention in the beginning that if the fetus is K negative, nothing to do, because if fetus is K negative, NTK in the maternal sample will not do anything. Even if it cross the uh, placenta, fetus does not have K antigen, so no chance of reaction. Now the next question was further management of the pregnancy. It means antenatal management of the pregnancy, delivery plan, and the uh, post-delivery follow-up of the mother and the baby. If you open BSH guideline, they have given two algorithms that makes the things very easy. They basically tell you how to manage a patient with red cell antibody. So if father is K negative or fetus is K negative, then there is no risk of HDFN. No further action should be taken in terms of NTK except for a routine testing at 28th week, which we do for every pregnant patient. But if the father is K positive or fetus is K positive, then this means that this fetus is at risk of developing HDFN. So this patient should be referred to fetal medicine unit for monitoring. Now there is a debate whether after referral for fetal medicine unit, should we do 4 monthly test for antibody till 28 weeks and fortnightly thereafter or not? I think yes, because if patient has one antibody, uh, there is a risk of developing other antibodies as well. So we should check the maternal plasma for any other antibodies with the same protocol, like monthly till 28 weeks and fortnightly thereafter until delivery. The patient should be followed by a MDT team involving obstetrics, hematologist, fetal medicine unit, anesthetics, and midwife. Delivery plan should be made for this patient in advance. And according to the BSH guideline, the ideal time for delivery is 37 weeks. The type of delivery, normal vaginal or cesarean section, depends on obstetric indication. So, in the fetal medicine unit, the team do weekly fetal middle cerebral artery Doppler ultrasound scan to check the peak systolic velocities. If the peak systolic velocity of the middle cerebral artery rises above 1.5 multiples of median, or if there are signs of fetal anemia, then the team decides an invasive treatment. Invasive treatment means intrauterine transfusions, which can be red cells or it can be platelets. In case the mother need any blood transfusion during the pregnancy, so it should be group matched. This patient blood group was ARHD negative. So we should give ARHD negative blood, K negative blood, because this patient has NTK, IAT compatible at 37 degree, and CMV negative. So CMV negativity is one of the indication for CMV negative blood up until delivery. And in and this blood cannot be issued by electronic issue because of the presence of antibody. So if there is no transfusion history of the mother, then the possible cause of NTD formation is immunization by previous pregnancy. So at this point, um, make sure that you know the specification of intrauterine red cells, intrauterine platelet transfusion. It can be a separate question of 3 to 4 marks, and there is no chance of mistake in these specification. You should remember them by heart. It can also be a part of the uh, MCQs and EMQs. Then do not forget the baby. Um, if you forget the baby in your answer, um, you may lose significant marks in this 13-mark question. So every baby at birth should be examined by neonatology team. They examine the baby for symptoms and signs of HDFN. Cord bloods are taken or venous samples are taken for full blood count, um, liver function test, including bilirubin, and if there are signs of hemolysis in the blood, then they send direct antiglobulin test or direct cum test as well. And if there is um, if there is a risk of HDFN, then the neonatal team decides whether to treat with neonatal exchange or phototherapy, whatever their protocols are. Then the mother, you need to follow up this patient in your clinic once. The patient would need antibody card, update the record of the patient. Most of the trust in the UK use electronic records now. So update the electronic record of the patient that this patient has antibody. So next time when it comes, then we can give her K negative blood if indicated. Give all the information, printed information on the websites related to antibodies in the pregnancy. And if there is indication of NTD, like if the fetus is D positive, mother is D negative, then that routine prophylaxis during pregnancy and on delivery, you have to continue with that. No need to stop NTD prophylaxis because of the NTK. It is a separate phenomena. Now, this is the algorithm for mm, to make it clear. Yes. So this is the algorithm for um, pregnancy with red cell antibody. This is given in a BSH. This is that at booking, all women should have ABO and D typing and antibody screen. If the antibody is clinically significant or not clinically significant. If not significant, repeat the testing at 28 weeks. If there is a significant rise in the titer, then you should be worried. Otherwise, no need to do anything. If clinically significant antibody is positive, then check which one is, are they anti-D, little c, big K. Then, as we discussed, paternal genotyping, fetal genotyping, monthly testing till 28 weeks, and then fortnightly till delivery timing, and uh, sorry, this picture is a bit big. Yeah, this one. So, if NTK is detected, it says to rate the antibody. If um, non-invasive prenatal diagnostic testing or test the father. If father is K positive, K negative, K positive but heterozygous. With K positive, fetus is at risk. Heterozygous, you need to do cell-fetal-free DNA. If K negative, nothing to do. Here, negative, nothing to do. If K positive, again, fetus is at risk. Then this says that refer to special unit, fetal medicine unit, deliver at 37 degree for the baby, cord blood, hemoglobin, bilirubin, and that, and management of HDFN as needed. These two algorithms are important. They are given in the BSH guidelines. Memorize them for the essay in part 1 and for the MCQs and EMQs as well. My request would be to subscribe to our channel, Hematology Lover, in the YouTube. Our team would continue to make small audio video discussion. We are trying to uh, regularize our morphology sessions as well. They are weekly on Saturday evening, but whenever we are on call, then we cannot conduct it. Then we usually select any alternate day. All of you are welcome to join the morphology sessions, and please, whenever my colleague posts a question in the Facebook group, um, try to answer them. he post the email address in the Facebook as well. Try to answer to that as well. uh, it would it is beneficial for you. It will be a practice of you for the exam purpose. So thank you everyone. See you with the next question next week. Thank you.